Hello, today we're doing the sensory systems of the head. Particularly we'll be doing smell, taste, and mostly we'll spend most of the time talking about vision and the eyeball. But overall, for sensory systems, let me remind you of the entire central nervous system, brain and spinal cord, and all the nerves that come off it for the peripheral nervous system. We have 12 pairs of cranial nerves, 31 pairs of spinal nerves that emerge from the spinal cord. And so, because we're talking about sensory systems of the head, it's important to recognize the 12 pairs of cranial nerves. If you look at the bottom of the brain, remove brain and look at the bottom of it, we see that to remove the brain from the skull, you have to cut all of these cranial nerves because normally they exit the skull at the cranial base. That's why they're called cranial nerves. They exit the base of the cranium. And well, we see what they do here, their function. They could be sensory, motor, or both. And we're not going to do all 12 today, but we'll do some of them. 1, 2, 3, 4, 6, 7, and 9. Just to give you an overview, 1, olfaction, that's smell. 2 is vision. 3, 4, and 6 are for moving the eyeball and also to help you constrict the pupil and help you, we call it lens accommodation for reading close, for close vision. And 7 and 9, you see the picture of the tongue there, those are for taste. So in addition to studying the functions of the cranial nerves, we also like students to study where cranial nerves exit the base of the skull because they're called the cranial nerves. And so you should be able to identify cranial nerves from a picture like this, of course. And when I want you to know where they exit the base of the skull, I'll mention it during my lecture. But remember this picture of the skull, the skull cap is removed and you're looking down on the cranial base. So the brain is sitting on top of that and the cranial nerves are exiting some of these little holes there to go to where their functional affected organs are. We'll start with cranial nerve 1, the olfactory nerve. So I just abbreviate cranial nerve CN. We always use the Roman numerals, Roman numeral 1. Olfactory nerve. So these nerves are numbered and they're named. So know the names and the numbers. And of course know the function. Olfaction is for the sense of smell. So it's purely a sensory function. And on the bottom of the brain you have this structure here. It's called the olfactory bulb. And here is the olfactory tract. So those are structures that consist of cranial nerve 1. Olfactory bulb. Olfactory tract. These are parts of the nerve that will transmit the sense smell. And notice that the bulb is right on top of this cribriform plate, and it's sending down little olfactory fibers through the cribriform plate, and those little holes are called the olfactory foramina. So note that olfactory fibers, they exit olfactory foramina of the cribriform plate. That's the ethmoid bone. Olfactory fibers exit olfactory foramina of the cribriform plate. That's the ethmoid bone. So what's going on there? those olfactory fibers right here that are exiting the cribriform plate are very important, because what they're doing is those olfactory fibers, here's the bulb, you can see there's like cells in there. So when you sniff, odor molecules get caught in this mucus layer, and the olfactory sensory neurons are there. Okay, that's why those olfactory fibers right there are so important. They're exiting there, and the cell body of the olfactory sensory neuron is right there, and they have these little olfactory cilia that are picking up those little odor molecules that trigger a cell response, sending it back towards the brain. So here we are, and we can see the little olfactory bulb there. And when you sniff through here, there's your nasal cavities, and the little odor molecules get trapped there. So know the olfactory epithelium. Oh, I'm sorry, let me get some Germans for you. So, in the olfactory epithelium, know those cells. The actual scent cells are just called olfactory sensory neurons. The cells around it are epithelial cells that just have a support function. They're simply called supporting cells. Note those, as well as the olfactory glands that secrete the mucus, which catches the odor molecules. So that's important too. So, supporting cells, as well as the olfactory gland. And moving on. Taste, done by 7 and 9. 7 is the facial nerve, cranial nerve 9, glossopharyngeal nerve. We're just doing the sense of taste for these ones. Here we see a picture of the tongue being innervated by 7 and 9, okay, these nerves. What I want you to know is that 7, if you follow it down, it's serving the anterior 2/3 of the tongue, those taste buds. Glossopharyngeal nerve is doing the posterior 1/3 of the tongue. The vagus nerve also plays a role in taste, but I mostly want you to know 7 and 9 for the sense of taste. Facial nerve, IX is 9, glosso, pharyngeal nerve. They both do the sense of taste or gustation. And so it's 7 that does the anterior 2/3 of the tongue, their taste buds. 9 does the posterior 1/3. Here's a picture of a taste bud. I think we all know what our tongue looks like. If you see a person licking an ice cream cone, and if you look at the tongue, the little bumped appearance, these little papilla, the taste bud's right there. If you look at an illustration of it, which is easier to understand, if you work the food down into your tongue, the food molecules trigger taste. Those microvilli trigger these cells, which are hooked up to the sensory nerve fibers. So you can see why they're called taste buds. They have a bud-looking appearance. So this is the special sense of taste. Now we're going to move on to the special sense of vision, carried by the optic nerve. So, cranial nerve 2, optic nerve. That's the special sense of vision. Here's the sphenoid bone, and the arrow is pointing to a little canal. It's called the optic canal. So I want you to know that the optic nerve exits the optic canal. And remember, that's the sphenoid bone. Here's a different perspective of the optic nerve exiting the optic canal right there. You can see going right to the back of the eyeball. And there's other nerves there that are shown. We'll just focus on optic nerve. Let's start with accessory organs of the eye, and we'll get to the sense of vision in a bit. But there's a lot to talk about with the eye. Here's a picture of a dissected picture of the eyeball with some of its accessory organs, and a further dissection reveals that there are a lot of eyeballs, a lot of muscles that move the eyeball. They're called the extraocular muscles, which we'll also talk about. But let's first talk about this thing called the lacrimal apparatus. This is basically your crying apparatus. It's for tear production. Eye accessory structures. So the lacrimal apparatus is for tear production. Let's look at a bigger picture of this, the eye orbit. What I want you to notice is you have your eyelids, of course you have your eyeball, but right here on the outside of the eyeball, let's look at a labeled picture. Those are the lacrimal glands. Those are actually the glands that produce tears. So of the lacrimal apparatus, it includes several things, especially that lacrimal gland. I just mentioned the facial nerve. We say that the facial nerve tastes because it does the taste buds of the tongue. It also cries because that gland is innervated by cranial nerve 7. So lacrimal gland, I'll put VII. I want you to know that this is innervated by that nerve, okay? And so we call that tear production. Every time you stimulate a gland, that's a motor function, a visceral motor function. So producing tears by cranial nerve 7 a visceral motor function. I want you to know that. So lacrimal gland is important. So, you know, your eyelids, when you blink, it keeps your cornea moist because the tears are swept from lateral to medial across the eye towards this area, and they call this area right here, the medial eye, the lacrimal lake, where tears kind of accumulate. And you have a drainage system for that right here. So other structures of that lacrimal apparatus include there's a little tiny bit of flesh called the lacrimal caruncle. That's kind of where you get the little stuff in your eye called the Sandman's eye. But right by that lacrimal caruncle, you have these superior and inferior puncta, which are little holes that lead to superior and inferior lacrimal canaliculi, these little drainage tubes that help drain the tears out. So I'll note the puncta, little orifices or holes that drain tears into the next structure. Puncta lead to the lacrimal canaliculi. A canaliculi is a small canal to drain the tears. So they drain tears into lacrimal canaliculi. Lacrimal canaliculi both drain into this big drainage tube called the lacrimal sac. So it's collecting all the tears. And then the lacrimal sac drains down, same tube, now you just call it down here when it gets down to the nose, nasolacrimal duct. So it collects tears, drains down too. Duct. That kind of like drains out into your nasal cavity down there. Usually not aware of tears draining down to there. You know, unless you're crying, you have excess tear production. You have tears spilling out there. You have tears, you get the sniffles. Okay. Okay, other accessory organs of the eye, we're done with lacrimal apparatus. I want to show you a picture of this view here. Here's the eyeball, there's the lens, there's the cornea, the window to the eye. But we have the eyelids and eyelashes, okay, which help, well, let's write that down. Eyelids, they protect eye, they keep the cornea moist, like I said, when you sweep tears across it. Protects eye, keeps cornea moist. The outer part of the eyelid is covered with skin. The inner part of the eyelid is covered with a mucous membrane called the conjunctiva. The conjunctiva. So outside of eyelids, covered with skin. The inside covered with conjunctiva. Inside of eyelids, covered with a mucous membrane. That is the conjunctiva. So that's what I want you to know there. It kind of forms a little pocket there because it lines right there, makes a fold. So they call that a fornix, a little pouch. And that fornix is actually where you put your contact lens, there and there. And just call it the conjunctival fornix. Where you put your contact lens. Where you insert contact lens. And of course, that membrane can get infected, and we call that pink eye. All right, let's talk about muscles that move the eye. We still haven't gotten to the special sense of vision, actually seeing yet, but again, there's a lot to talk about the eye. And when we talk about moving the eye, we call them extrinsic eye muscles. Extrinsic means because they're outside the eyeball. They attach to the whites of your eyes and they pull it in different directions and move your eyes around. There's 6 of them, so we kind of teach them in 3 pairs. And there's actually 3 different cranial nerves that innervate those muscles that help you move your eyeball. Cranial nerve 3, 4, and 6. 3, 4, and 6. The oculomotor nerve, the trochlear nerve, and abducens. Okay, and so I point to them there. You can see them 3, 4, and little one there 6. Should be able to identify them. Here's another view of 3, 4, and 6. Study this picture, and I have them labeled there. 3, 4, and 6. Notice how they're coming off the brain stem right around the pons. Okay, there's midbrain, pons, medulla. Once again, midbrain, pons, medulla. Most of the cranial nerves emerge from the brain or brain stem. Here we have a picture of a dissected eye orbit. We can see the eyeball, and there's muscles that surround the eyeball, and they can pull the eye in different directions. And I want you to know these extrinsic eye muscles. We'll just call them muscles that move the eye. So know the anatomy, be able to identify the muscles and know their function, how they roll the eyes this way or that way. Extrinsic eye muscles. So note the superior rectus and inferior rectus. That's the first pair. These are both innervated by cranial nerve 3. So know that. Superior rectus helps you look up. Inferior rectus helps pull your eye down. So if it's on top, it pulls your eye up or helps pull your eye down. I think that's easy enough to understand. So superior rectus helps you look up, helps you look down. That's the first pair. Second pair, medial rectus, lateral rectus. The medial rectus muscle, innervated by cranial nerve 3, it's going to pull your eye in. So for example, if you're looking that way, this eyeball is turned in. That's medial rectus. If you look the other way, this eyeball is turned in. That's medial rectus. Okay? Lateral rectus is innervated by cranial nerve 6. The name for cranial nerve 6 is abducens. That's the number 6. The name is Abducens Nerve because cranial nerve 6 abducts the eye. It helps pull the eye laterally. So, lateral rectus pulls the eye, it abducts the eye, or this one here, it abducts the eye when you look the other way. So I guess to match this description, you could say it adducts the eye, turns eye medially, or you can say abducts eye, turns eye laterally. Next pair, superior, inferior, oblique eyeball muscles. The superior oblique is innervated by a nerve called the trochlear nerve. It's cranial nerve 4. The trochlear nerve is called that because the muscle it innervates, the superior oblique, it runs through a pulley right there. See, it takes a turn right there. So the tendon runs through that pulley, and a pulley is a trochlea, so hence trochlear nerve. The inferior oblique, that is cranial nerve 3. Well, anyways, the superior oblique, look at this eyeball here. We call it your cheater muscle. It helps you look down and laterally, like when you're cheating off someone's paper. We don't want you to do that, but so that eyeball, superior oblique, we call it your quote-unquote cheater's muscle. But really what it does is it helps the eyeball look down and laterally. Look down and laterally. The inferior oblique helps you look up and laterally. We call it your angel eyes. Well, like when you accuse a small child of doing something wrong or lying, they kind of don't look at you. They're, oh, I didn't do anything. Oh, I don't know. You know, angel eyes. They didn't do nothing, but you know they did. Okay, well, moving on. Those two muscles. One more muscle. It doesn't move the eyeball, but it helps lift your eyelid, and it's called the Levator Palpebrae Superioris. That's the name of the muscle, also innervated by Cranial Nerve 3. So if someone has a droopy eyelid or can't move their eyeball one way or the other, they may have an impairment to the cranial nerve 3 because they all come off the brainstem. You worry about head trauma in those patients. So it's a muscle, it's literally right there. I point to it there and I point to it there. Okay, there it's cut off. But there you can see it kind of go into the eyelid right there. So it helps lift your eyelid. And you open your eyes. Again, innervated by oculomotor nerve, cranial nerve 3. So moving your eyeball or opening your eyelids, that's voluntary movement. So moving your eyeball, we call that somatic motor function, okay? Because all these muscles that we're talking about are skeletal muscle. So a voluntary muscle is somatic motor function. You move eye, lift eyelid. Those muscles are skeletal muscles, so it's somatic motor function. Okay, you know, I forgot to do questions for you, so let me type some in real quick and we can kind of do it as we go along here. All right, there you go. Take a minute and figure those out. See how you're doing here. Name each eye muscle. Name the eye muscles innervated by each cranial nerve. There are 3 cranial nerves, 3, 4, and 6. The ones that 3 innervates, they're superior rectus, inferior rectus, inferior rectus, medial rectus, inferior oblique. The trochlear nerve innervates that cheater muscle, superior oblique. 6, the Abducens nerve innervates lateral rectus, abducts the eye. Name the main structures of the lacrimal apparatus. So for number 2, it starts with the tear-producing gland, innervated by 7, the lacrimal gland. Always know the innervation of your glands, that's 7. And, well, it's swept across the eye. When you get to the medial part of your eye, I said you have the lacrimal truncle. You have the superior inferior puncta. Just no puncta, those are little orifices that lead to the lacrimal canaliculi. And those drain to the lacrimal sac. Which drains down to the nasolacrimal duct. Which cranial nerves are for olfaction and taste? Olfaction is 1, taste 7 and 9. So 7 is a mixed nerve. It tastes and it cries. Moving on to eyeball tunics. Well, if you were to remove the eyeball, get the little round eyeball, you remove all the tissue and fat and all the, get it down to the little white round eyeball and cut that thing in half. We have this picture and you can start to peel away the layers of the eyeball wall. There are 3. The outermost layer is called the fibrous tunic. Eyeball tunics. Tunics means shirts, it means layers. So the layers, outermost layer, fibrous tunic. You should note the sclera and the cornea are this outermost layer. So most of the eyeball is just the whites of your eye. The sclera is just the tough white part. clear window to your eye, that's the cornea. Window to the eye. The middle layer, there's quite a few things here. The middle layer, most of it is this layer called the choroid. The choroid, it's pigmented, it's dense, it's vascular. That's where the blood vessels are. And it's the middle layer between sclera and retina, which, as we'll see, is the innermost layer. So we'll call them this middle layer the vascular tunic. We'll just go with vascular tunic. No, it's the middle layer. Okay, so the vascular tunic, choroid is where you have most of the blood vessels, but you can see blood vessels shoot out, and they're all throughout the choroid. Now, as you go to the anterior part of the eye, there's more structures here. We have this ciliary body, which kind of radiates out. The oral serrata, I'm not going to have you know, but I do want you to know the ciliary body. Inside there is a ciliary muscle that helps it helps the lens bulge so you can see things close in front of your face, like as in reading. So ciliary body, within that body you have ciliary muscle. That muscle is important because it's attached to these suspensory ligaments, which are attached to the eye. The eyeball lens right there, that's the lens. That really helps you see far away and helps you see close. Ciliary muscle attaches to suspensory ligaments. They're suspending the lens, quote unquote. Suspend lens. So that's important for focus, to focus your lens, and we'll get into that. Well, anyways, those are all part of this middle layer, this vascular tunic. Notice one more thing, the ciliary body, but then this part that goes up that way, partially over the lens, is the iris, where you have your beautiful brown eyes or blue eyes, right? The iris, the colorful part of your eye. Still on the vascular tunic. I just say colorful part of eye, but also the iris has smooth muscle as well to help you constrict or dilate your pupil. So the smooth muscle of the ciliary body and the iris, that's all innervated by cranial nerve 3. Okay, so 3 is very important for the lens and for the iris. So smooth muscle, lens, that control the lens, and iris. More slides on that. Let's get to this innermost layer called the neural tunic, or the retina. Well, the neural tunic is hooked up to cranial nerve 2. This is where you have the sense of vision. And so this yellow layer, the innermost layer, has fibers that go back, and they actually form axons of the optic nerve, which is the sense of vision. And, well, the retina has the photoreceptors. These are the cells that actually bind photons of light to help you see. We'll get into that. Other parts of this neural tunic include this spot here, this disc here, and this spot there. So this here, where the cranial nerve, optic nerve kind of emerges from the back of the eyeball, that's called the optic disc, or your blind spot. It's called the blind spot because there's no photoreceptors there. And you have the axons that carry the sense of vision out, but no photoreceptors, as we'll see. But then you have the most important thing there, the macula lutea, which means yellow spot. Let me erase this. Still on neurotunic. Name for how it appears when you do an eye dissection, a yellow spot. So imagine you have this yellow spot, and in the middle of that, about 1.5 centimeters, right in the middle of that yellow spot, is the Fovea Centralis. So this whole thing is the macula lutea, but that little spot right in the middle, either called the fovea, or its full name, Fovea Centralis, because it's in the center. You have your highest concentration of cones there. There's rods and cones. Cones, as we'll see, are the photoreceptors for color and sharp vision. So when you look right at someone, the lights are on, you can see them clearly. That's cones. You're focusing all the rays of light right there so you can see them clearly. So just note for now, cones are for color vision. Sharp acuity. When you go for an eye exam, sometimes they dilate your pupils. So that way, they can see the back of your eyeball, the retina. So your pupil is right there. It's the whole of your iris, I should note that. I'll just describe it as hole in the iris. So the rays of light, it first goes through the cornea. It's got to go through your pupil, through the lens, which helps focus the rays of light back to the eyeball right here, to the fovea. Okay, so when you go to the eye doctor and you dilate the pupil, they usually give you eye drops. It kind of numbs, it dilates it in. Basically, you get a nice view of the back there, and this is what the examiner sees. The macula lutea, which presents as a darker spot, and a brighter spot where you can see the blood vessels emerge out, is the optic disc, and they can tell if there's abnormalities there in your retina when you go for an eye exam. Again, they call this the blind spot. There's no photoreceptors there, and to prove that to you, if you were to print this out, this plus and this dot, if you were to close one eye, stare at the plus, holding the paper close to your eyeball, move the paper back, staring at the plus, and at some point, the black spot disappears. That's because at the point where it disappears, the light coming from the black dot is shining on your blind spot where you have no photoreceptors. Okay, but normally the blind spot doesn't exist because both eyes are open and the other eye compensates for the blind spot. All right, so looking at that same picture, let's teach the eyeball chambers and cavities shown here. This big chamber behind the lens, we call that posterior cavity. It contains a vitreous humor, like a gelatinous jelly. It helps maintain a proper intraocular pressure. Area posterior to the lens, it's filled with a vitreous humor. Filled with a vitreous humor, it helps provide proper intraocular pressure. You want that pressure to be the right amount. They can measure that when you go for an eye exam. And when you pull on your eyeball, you don't want the eyeball to collapse as you pull on it. And also, you don't want the pressure to be too high. If you put too much pressure in the eyeball, you can crush the retina. It can start to affect vision and have other things happen. Well, anyways, this area in front of the lens is the anterior cavity. It's filled with an aqueous humor. Now, this anterior cavity is subdivided into an anterior chamber, a posterior chamber. What I'm pointing to is the posterior chamber is this little space between lens and iris. Posterior chamber within the anterior cavity. So posterior chamber, space between lens, iris. Anterior chamber, space between cornea, iris. That's the cornea, the window to your eye. Let's have some more questions for you. Let me type them up real quick. You can fast forward, hit the pause button, or take a break, but let me type these up. Real simple. Right there. You work on that, I'll be right back. Right, I'm back. Sorry for the delay. All right, 3 layers. Outermost layer, fibrous tunic. Middle layer, vascular tunic. Innermost layer, the neural tunic. For the fibrous tunic, I want you to know sclera cornea. For that middle layer, the vascular one, I want you to know the choroid, the ciliary body, which is attached to suspensory ligaments, which suspend the lens. Also, you have the iris pupil. Okay. For neural tunic, I want you to know, well, it's got the retina with macula lutea within the center of that, Fovea Centralis, and know the optic disc with the blind spot. All right, now we can move on. The function of the lens. Alright, so there's the lens, and it's being suspended by those ligaments, and there's the ciliary body. Basically, this is autonomic function, okay? An autonomic function in terms of the nervous system usually has opposing dual innervation. So the sympathetic function is the opposite of the parasympathetic function. Autonomic NS, nervous system, has two divisions, sympathetic, parasympathetic. Sympathetic division. And there's many examples. This is just one of the parasympathetic, sympathetic example. The sympathetic response for vision is for distance vision. In distance vision, just see far away. So you're outside, you can see across the stadium, you know, down the field, down the road, whatever it is. See far away. In that scenario, the ciliary muscle, it's relaxed, and when it relaxes, it pulls those suspensory ligaments, here called the zonular fibers. It pulls them tight. The lens is stretched thin. So for distance vision, ciliary muscle is relaxed, but that helps stretch the lens tight. Okay, and stretching the lens, that helps you see things far away. So it focuses right on fovea. That's the whole thing about seeing things clearly, whether it's far or close. You focus it right on the fovea. It flips it upside down, but your brain turns it right side up. So they show you R flipped upside down, your brain flips it right back up. I'm not really focusing on that. The point is this: stretch lens, see far away, sympathetic function, okay? Parasympathetic function, that's our cranial nerve 3. So I do want you to know that. Parasympathetic it's for close vision. Close vision. And that's where the ciliary muscle, which is innervated by cranial nerve 3, it contracts. And when that ciliary muscle contracts, it contracts in a way where it kind of like closes up. And when it closes the space, it allows those fibers to relax, and it allows the lens to relax and bulge. And that bulging is important. When the ciliary muscle contracts, lens bulges to accommodate for close vision. You know, as in reading. Reading is close vision, and they call this whole thing here, this parasympathetic function, lens accommodation. You're accommodating, trying to read close. So call this whole thing, I'll squeeze it in over here, lens, quote unquote. Lens accommodation, that's what I want you to know. And of course, as you, well, maybe you don't know, starting around mid to late 30s, early 40s, as you read, you start to notice, oh, I have to like hold it farther and farther away. That's because as you get older, 30s and late 30s, early 40s, when the muscle contracts, the lens bulges less. It doesn't bulge as much. It bulges very well when you're young. As you get older, that's when you need reading glasses. You need a little help. Okay. So if you need corrective lenses, what the lens are correcting is for if your eyeball is too long or too short. If you're nearsighted, just take a look at this figure for a second. Okay, let me clear the board and I'll explain this figure. If the eyeball is too long, the rays of light will cross in front of fovea. So to correct for that, this concave or diverging lens, it diverges the light rays a little more before it hits your lens, so that when your lens bends the light rays, it'll converge, it'll cross right at the correct point. So this concave lens, the diverging lens, corrects for if the eyeball is too long for a myopic eye. Diverging lens corrects for an eye too long. Of course, you can have an eyeball that's too short. If you have an eyeball that's too short, the light rays will cross behind. So to correct for that, a converging lens will start to bend the light rays inward before it gets to your lens, which will bend them further, and the light rays will cross at the correct point. A converging lens corrects for an eyeball that's too short. And moving on. So that's the lens. Focus, or it's stretched out to help you bend the light rays right on the fovea. The other thing is the constriction and dilation of the pupil. So in this picture here, we can see that the iris, the colorful part of your eye, inside of that actually has smooth muscle that can constrict or dilate the pupil. Okay? I want you to know that constriction is a parasympathetic function. Pupil constriction, parasympathetic. Sympathetic function. Dilation. So this happens on a sunny day. This happens in a dark room. You want to let more light in a dark room so you can see a little bit better. On a sunshiny day, you want to constrict the pupil. It helps keep harmful UV rays out. I call this your biological sunglasses. This is actually better than wearing sunglasses, because by wearing shades, this will happen. But if those sunglass shades that you're wearing don't have UV protection, you're harming your eye by allowing the pupil to dilate and letting the harmful UV in. So be sure that your sunglasses have UV protection. But just don't wear sunglasses. And this will happen naturally to protect your retina. So one clinical situation is, if you ever heard the term, if they do like a pen light where they shine a light on your eyeball and it's supposed to constrict the pupil. Maybe you'll be in some kind of mid-constriction, but if you shine a light, it should constrict the pupil further. And if that reaction doesn't happen, it means that this parasympathetic function is impaired. Let's remember, this is cranial nerve 3, which is right off the brain stem. Sympathetic nerves are actually inferior, down in the spinal cord. Inferior in spinal cord. So they're down further in the vertebral column. If you have a head trauma victim and they're unconscious and you're trying to do some kind of assessment and you do the little pen light thing, and you say the pupils are fixed and dilated. That means they're like this, you shine the light, it doesn't constrict. If they're dilated, it means this is wrong. So what you have to know about this parasympathetic, sympathetic idea here is, if one nerve is damaged, the other takes over. So if you're concerned with brain trauma, and you know that this nerve comes off the brain stem, this is a quick assessment to see if there's any swelling inside the brain, right? Because if the pupils are fixed and dilated, this one's taken over because there's swelling in the brain. It might put a kink in this nerve, making this nerve not work properly, so it won't respond to the pen light. It'll be either fixed like this or like this. And that's something you should know, okay? So I'm going to move on. And so let's kind of talk about the sense of vision in terms of the cell physiology. So we're getting into the physiology part of anatomy physiology here. We want to talk about the photoreceptor. We taught the eyeball tunics, 3 layers, from outer to inner, sclera, choroid, retina, okay? So here's our optic disc right there, but let's kind of look at this chunk right there. So this chunk of cells is kind of pulling it from right around there. And our 3 layers of cells, the light rays come this way. The photoreceptors are right there, stuck in this little pigmented layer of the retina. And if there's light and the sense of vision gets turned on, the sensation of vision goes that way, okay? So light goes this way, but the signal transduction, we call it phototransduction, occurs this way. So they kind of occur in opposite directions. So what we see in the retina, the organization is 3 rows of cells. And you know, when the eye doctor checks your retina, they can see these 3 layers of cells. Retina is composed of 3 layers of cells. The rods and cones, those are your photoreceptors. These bipolar cells, ganglion cells. Photoreceptors rods and cones. That's one layer. Bipolar cells. That's another layer. Ganglion cells is the third layer. That's the last layer. So the axons of these ganglion cells, they actually form the optic nerve that sends the sense of vision back to your occipital lobe, which is the part of the brain for vision. Axons of these cells form cranial nerve 2, optic nerve. Let's look at those rods and cones. Cone, rod. So what we see from this picture here is that the rod and cone photoreceptors are named for the shape of this outer segment. Okay, so this inner segment is like kind of like the regular cell cytoplasm items, and then you have these little synaptic endings which can communicate with the bipolar cells. Okay, so rods and cones, the photoreceptors. Named for the appearance of the outer segment. So those outer segments have these organized layers of the visual pigment or photopigment. Okay, so that's why they're so important. The outer segment contains the visual pigment or the photopigment because they bind photons of light. Light is kind of like photons of these waves of photons of light that help us see color. So the visual pigment literally binds photons of light. You'll have to take a physics class if you want to learn more about the properties of light. Here, just refer to light as photons of light. They literally bind a pigment. It triggers some cell physiology that we'll talk about in just a second here. But let's take a closer look at this visual pigment here. Okay, so for the photoreceptors, the outer segment has this molecule here. Detection of light by the eye is possible because of the photopigment rhodopsin. Visual pigment, aka photopigment rhodopsin. You can see it's this big globular shaped protein in the cell membrane. That's the opsin part, it's the protein part. It's kind of drawn like this. Of a dumbbell shape. That's opsin. Then you see this skeleton key shaped structure. That's the retinal. That's a chromophore. That's the thing that directly absorbs the photons of light. So it's kind of a bent skeleton key. Kind of like that. That's retinal. binds photons of light. It's normally bent, but when it binds photons of light, that skeleton key stretches out. So this is the visual pigment. So for color vision for the cones, you have blue cones, green cones, and red cones. And here's the visible light spectrum, which is a very small spectrum of the whole electromagnetic spectrum. Gamma rays, X-rays, UV rays, which have a smaller wavelength. They're more powerful, more damaging to biological tissues. You have infrared, microwaves, radio waves. Well, anyways, again, you have to take a physics class to learn about this whole spectrum here. We're just concerned with this small spectrum, which is the visible light spectrum. What happens is the blue cones are called blue because they're maximally stimulated. They call this light absorption percent of max. They max out in the blue, and then they max out in their respective color ranges there. So for the cones, it's the blue, green, the red. The rods max out at about 500 nanometers. I'm not going to test you on these numbers. I just want you to get that the concept of color cones, why they give certain color sensations that we see in the sense of vision, is because of where they max out in terms of where they absorb photons of light. Okay. All right. So in phototransduction, what we're going to talk about here are these visual pigments here in the outer segment. What happens in the whole cell, in this chain of cells, called phototransduction, because you're transducing this sense of sight through these three chain of cells. This one chain of cells, three cells. Okay, I'm sorry, can't get the words out this morning. Let me write it down. This is the topic of phototransduction. It's the cell physiology. I'll describe it as cell signaling through three cells: photoreceptor, bipolar cell, ganglion cell. Photoreceptor, bipolar cell, ganglion cell. Those three cells. So again, let's contrast the two different photoreceptors, the rods versus the cones. Then we'll talk about generically what we see here. That looks like it's giving the rod photoreceptor as an example. Cones, that's for color vision. Rods don't see color at all because color vision is for when the lights are on. So, so when the lights are on, you can see color. But when the lights are off, you don't really see a lot of color, do you? In dim light or a dark room, that's when you use your rods, okay? When you kind of like can see a little bit, when there's a little light in the room. So we say that the rods are for dim light vision. We say that cones are for color vision or for sharp acuity. For dim light vision, it's more like peripheral vision. You don't see things that clearly.
peripheral vision, like for example in a dark room, you can kind of see things move on the side, and it's really when the lights are on that you look right to someone and you use your cones. Rods are for dim light, kind of peripheral vision. All right, like groping around in a dark room. Well, anyways, in both, whether it's rods or cones, they're both using this same phototransduction mechanism. Okay. It's kind of like, well, if you ever went to the movies, it's dark in the movie theater, your eyes are adapted for dim light vision. But then you walk out and it's like a matinee and it's bright outside and there's like a glare because it's too bright. That's because the photoreceptors for dim light vision, they're being oversensitized. So you kind of have to wait until the cones kick in, which require more photons of light. So a bright day, you just wait for your cones to work. It takes about a minute, and then it's not so you're not so shocked by the bright day when you leave a movie theater. All right, so getting to this, when you're in a dark room, say in a movie theater, or just turn the lights off, for example, we have what's called a dark current. In the dark, you basically can't see, right? So you don't see much, and you're using your rods. Turns out, in the outer segment of the photoreceptor, there's a dark current. What it says here are the details. There's cyclic GMP gated channels that are open. They're allowing this cation influx that depolarizes the photoreceptor to -40. It's usually -70. It goes a little bit less negative, more positive, to -40. So in the dark, there's a dark current. It's a cation influx into this outer segment. So that depolarizes the cell to -40. So basically, the cell is on. But when the cell is on, what it does in its synaptic endings, it secretes these IPSPs. Those are inhibitory postsynaptic potentials. You may not remember that, so I'm going to write out inhibitory. So when you're depolarized, you stimulate, the photoreceptor secretes IPSPs. Those are inhibitory. Inhibits. IPSPs inhibit the bipolar cell. So the dark current depolarizes, I should write that word. Okay, -40, that's millivolts. This inhibits the bipolar cell, so write this down, that's the key. You turn that cell in this chain of cells off. That means no action potential is there, that means can't see it because it's dark. Turn off. If you turn off the bipolar cell, the ganglion cell will also be off. So, keys for understanding this, when you're in the dark, the reason you can't see is because of a dark current. The depolarization makes the cell turn off bipolar cell, which then turns off ganglion cell. There's no action potentials there. Nothing is transmitted. You're not going to see it. So for turn ganglion cell off, let's put it more in a cell physiology way. There's no action potentials. There's no APs, Okay, so let's say you turn the lights on. In the light, what happens is you close those channels, you eliminate that dark current. So let's kind of write the steps down. When you turn lights on, you use your cone, you can see color. Okay, you're not groping around in a dark room, dark movie theater. Turn lights on. What happens is eliminate dark current. Close channels. There's no dark current. That hyperpolarizes the cell to -70. So it's not depolarized, it's hyperpolarized. That's like turning the photoreceptor off. But what that does is now you stop those IPSPs. Now there's no inhibition. With no inhibition, you turn on the bipolar cell. Okay, that's the difference here. Before it was off, now it's on. Bipolar cell on, and when that cell's on, it secretes EPSPs, excitatory postsynaptic potentials, to turn on the ganglion cell. So EPSPs turn on ganglion cell. It fires APs. So when you fire APs, those axons right there form the optic nerve. Okay. So I want to show you this next picture. Here's our phototransduction. In this picture, the rods and cones are green. There's our bipolar cell, ganglion cell. It's the axons of the ganglion cells that form the optic nerve. So you can clearly see that right there. And I wanted you to know that about ganglion cells. Those APs, when they fire along those action potentials, those actually form the optic nerve. To take even a more micro view of phototransduction, let's just kind of look at the dark current, whether it's on or off. In the dark, you got dark current. You can see it right there when these channels are open. That's the dark current. Okay? So associate dark current, this channel is open. What happens when you turn the lights on? Well, then this events happen in the phototransduction. There's the light. It turns that skeleton key from bent to straight. Okay? They call that cisretinal to transretinal. So let's note that. So there's light. Okay. There's our skeleton key bent. That's called cisretinal. But when it binds the light, it changes to a straight skeleton key called transretinal. When that happens, the visual pigment activates transducin, which moves along the inside and attaches to a phosphodiesterase, which activates that. So, this visual pigment here would then activates transducin. So write that down. Then write down transducin moves along, activates phosphodiesterase. A lot of times I abbreviate phosphodiesterase PDE, but what that activated PDE does, it converts cyclic GMP to GMP. I'll just kind of draw it like this. Phosphodiesterase, it takes cyclic GMP, converts it to GMP. What you got to know is that the cyclic GMP allowed the dark current. So when you get rid of it, it closes the channel. And that helps you see because it eliminates the dark current, remember? So let me get rid of that. So let's review. Light comes, first of all, you're in the dark, those channels are open, dark current. Light comes along, boom, straight skeleton key, that activates transducin, activates phosphodiesterase, you convert cyclic GMP to GMP. When you get rid of the cyclic GMP, you close these channels. You decrease cyclic GMP, close channels, you eliminate dark current. And that's when the cell hyperpolarized back to -70. Oops, sorry, wrong way. Right there. Eliminate dark current, cell hyperpolarizes to -70 millivolts. That's what we said right there. So that's kind of what that slide was showing you when you're in the light. So no phototransduction from this slide. Another clinical side topic that we usually teach is color blindness. In color blindness, there's a defect or missing cone, either the red one or the green one. Those are the commonest cones that are missing in color blindness, and it's usually an X-linked condition. So usually males are affected, and usually females, they have regular color vision, but they're carriers. So I want you to know the genetics of color blindness. It's either a defective or missing red or green cone. It's X-linked, So it's male affected. Because for the male genotype, XY is the genotype for males. XX is the genotype for females. So let's just kind of like learn from this figure here. Because it's X-linked, if you're a man, you only have one X. So if you've inherited the colorblind genetics, you've only got one X, you'll be colorblind. Okay. So let's do this cross here, where a colorblind man, normal woman, they have kids. Okay. Now look at the males. The males are normal, right? Because if you're a son of this man, what did you inherit? Your sperm in the man is either going to have the X or the Y. So the reason why the sons are normal, you inherited the Y from your father. That's why you're a man. You can't inherit from your mom. Mom doesn't have it. Okay, so that's why the sons are normal. But what about the daughter? The daughter is inheriting the X chromosome that has the defect or missing red-green cone. That's why the daughter is a carrier, but she has normal vision. Now, if this daughter marries a man with normal vision and they have kids, let's kind of see if this makes sense here. And so, carrier is going to be let's say the black is normal, the red X has the missing or deficient condition. So that's carrier. Okay, if she has a son, there's a 50-50 chance the son will be colorblind. Why? Because, well, there's a 50-50 chance he got the bad X and he got the normal Y from the father, but it's X-linked. That's why if you have a daughter, 50-50 chance she's a carrier, okay? But she'll get the normal X from father. So that's that genetics. And there's simple tests to see if you're red-green colorblind. A person with normal vision sees the number 7. Okay, those who are colorblind usually don't see any number at all. Over here, people with red-green colorblind can either see a 3 or nothing. Those with normal vision see an 8. So it's a simple test for you right now. All right, so more topics. When you see something, it goes back to your visual cortex right there. And we call that the visual pathway, and we do want you to know that. So just to remind you, the optic nerve exits the optic canal. That's the sphenoid bone. That's what I show you there. Here you can see the optic nerve exiting, but they cross right there at the optic chiasm. And then it becomes the optic tract. So distinguish between those 3 things. Optic nerve, optic chiasm, optic tract. So we can kind of look at the visual pathway from this view here. Right here, there's the visual field, and we can kind of see how this pathway progresses from front to back. call this the visual pathway. Sorry, sloppy. The visual pathway. So what we see is that we have the right and left visual fields. Left and right visual fields. In the middle, you have a center point. And, well, each eyeball actually carries information from both left and right visual fields. When I talked about Mr. Split Brain, we talked about this before. So now let's note that the optic nerve carries information from both fields. Info from left and right visual fields. But when they cross at the optic chiasm, that's where things change. After the optic chiasm, each optic tract only carries information from one visual field or the other. So, the left optic tract is carrying information to the left brain, but it only has information from the right visual field. So I put R for right, visual, F for field, just because I'm running out of room on the whiteboard there. The right optic tract is carrying information from the left visual field. Notice that information is being routed from the lateral geniculate nucleus of the thalamus. So it goes from optic nerve, optic chiasm to the thalamus. Optic tract will carry it all the way back to the occipital lobe. Okay, so I didn't write those on my whiteboard, but thalamus, occipital lobe, you should know that from the visual pathway. We're starting from the retina right there. Once again, optic nerve, optic chiasm, thalamus, optic tract, all the way back to the occipital lobe. And so look at it this way here. So imagine each eyeball is carrying information from the optic nerve, both visual fields in each eye. So for example, let's say you had, for whatever reason, loss of vision, blindness in one eye, completely blacked out. Well, you still have information from both visual fields from the other eyeball. However, after they cross the optic tract lesion here, what you do is you lose the right visual field in both eyes. So that's why where they cross is very important. If you have a lesion here versus here, it makes a difference in what you lose. So I want you to know the difference. If you lesion, let me write that down for you. All right. Lesion means damage. Let's say you damage the optic nerve. You lose both fields of vision for that eye. Loss of both left and right visual fields of one eye. But if you lesion or damage the optic tract, this condition here, loss of left or right visual field in both eyes. So in this example here, you damage this tract right there, you lose the right visual field in both eyeballs. If we were to do a cow eyeball dissection, this is what you would see. Well, the parts are all laid out nicely. That's the cornea, that's the lens, that's the pupil, so that dark area around it is the ciliary body. That glob of jelly is vitreous humor, and this one you can even see the Fovea Centralis right there, and that opaque layer on top of the dark layer, that opaque layer, that's the retina. And so, yeah, that's a nice cow eyeball dissection, if you should do that in the lab. And that's the end of the lecture. I know that was a long lecture. I don't want to have any more questions to answer, but you know, do expect to see all that information on a test or quiz. Try to make your own questions there. And I'll stop the lecture here. Thanks for watching.